Oh, so this means we're ready. I should get started. Okay. Um, we're ready, Kathy? Sorry,
Nope,
Yeah,
that's
we are
it.
live now.
oh, okay,
We're
good.
live.
Okay, sorry, that was silly. I'll just take another sip of coffee and call the meeting to order. We'll start. The first item will be a roll call, which Kathy will start.
Okay, good morning, everybody. Rebecca.
Here.
Okay, Elaine.
Here.
Bella.
Here.
Eric.
Here.
Martha.
Here.
Robin.
Here.
Dimitri. Okay, Secretary.
Here.
Nancy.
Morning, Kathy. I'm here.
Morning. Matt.
I'm here.
And I believe and confirming that Michael is not joining us today. Thank you, everyone.
Okay. Thank you, Kathy. You're still up because the first item on our agenda is approval of the minutes from the February 8th, 2024 meeting.
Mhm.
Could I have a motion?
Motion.
And a second?
Second.
Okay. I will now ask Kathy to call for the board vote to approve or accept the minutes with any changes.
Okay. Rebecca.
Yes.
Elaine.
Yes.
Bella.
Yes.
Eric.
Yes.
Martha.
Yes.
Robin.
Yes.
Secretary.
Yes.
Nancy.
Yes.
Matt.
Yes.
And I'm just going to confirm that Dimitri is not with us. Okay, thank you, everyone.
Okay, well, the motion carries. Thank you. The first item on the agenda is the executive director's report, where I will drink coffee and listen, and Audrey can take over from here. Thank you.
Sounds good. Thank you, Secretary. Good morning, everyone, and welcome to today's meeting. I want to start off today by sending our well wishes to our friend and colleague, Division of Insurance Commissioner Gary Anderson. Gary is leaving his post as DOI Commissioner tomorrow and will be serving as the CEO of the National Association of Insurance Commissioners. The association's gain is certainly our loss here in Massachusetts and at the Health Connector. Gary was an active, thoughtful participant on our board and partner to the Health Connector for a number of years in countless ways that our agencies collaborate on matters big and small, and we'll miss him. Rebecca Butler remains our DOI board representative, and we continue to appreciate her insight and experience in this forum and in her role at DOI. So thank you, Rebecca.
Yes. Sorry, I just wanted to say that we definitely will miss Gary tremendously at the Division of Insurance. In addition to being smart, competent, reasonable, he's also one of the nicest guys around. So kudos to the NAIC for getting him. It's sad for us, but we will have Rachel Davison as interim acting commissioner, and she has many years of experience and is incredibly smart and detail oriented, and I think we'll all do very well as having her as our interim commissioner. But we are sad to see Gary go, but very happy for the NAIC to get such a great person.
Thank you, Rebecca. Agreed. So congratulations to Gary and best of luck in his new endeavor at NAIC. And so to continue with the theme of celebratory milestones, I wanted to note that tomorrow marks the 18th anniversary of the Commonwealth's landmark state health reform law, Chapter 58, being signed into law. This law not only established Massachusetts' fundamental position that everyone should and could have meaningful health coverage, but it also, of course, created the Health Connector. The state health reform law is the foundation on which we built everything here in Massachusetts in terms of expanding access to health coverage. And of course, it was the model for the Affordable Care Act. In just the last decade alone, the Health Connector has provided health insurance to more than 1.1 million Massachusetts residents at some point or another. Today, we have our largest total enrollment in the Health Connector's 18-year history, with 350,000 Massachusetts residents now enrolled in health or dental coverage with us. And nationally, enrollment trends have been similarly historic, with more than 21 million people now in ACA marketplace plans, all traceable back to what Massachusetts proved was possible nearly 2 decades ago. So I'm very excited to say one day early, happy birthday, Chapter 58 of the Acts of 2006, and also say a heartfelt thank you to everyone here in Massachusetts who fought to conceptualize, advocate for, negotiate, pass, and implement that historic law. And another marker of time, 14 months ago, in February of last year, we came to this board with our first in-depth discussion on the MassHealth redetermination process. And we committed to providing in-depth updates at every board meeting throughout the duration of the redetermination period. Today, we'll bring you our final board meeting update on redeterminations with our colleague from MassHealth, as MassHealth has now completed checking the status of all 2.4 million people in Medicaid coverage as of last April. Together with MassHealth and Healthcare for All, we undertook an unprecedented outreach and messaging campaign to encourage people to act now and stay covered. For our part, through March, more than 120,000 people have come into Health Connector coverage after being found no longer eligible for MassHealth. We do anticipate that more people will continue to enroll. Some people are still in the middle of the redetermination process and won't get eligibility updates for another month or so. And we will provide updates as we wrap up this unprecedented undertaking that is ending with the Health Connector enrolling more people than ever before in its 18-year history. And as we tee up this final co-presented update on redeterminations with MassHealth, I want to personally acknowledge and thank the leadership and staff at MassHealth for the example they set nationally on how to approach this challenging and historic undertaking, and how closely they partnered with us during this period. And a special thanks to MassHealth COO Elizabeth Lamontagne for sharing her time and expertise in these updates for the board over the last year. We had initially planned to share at today's meeting an update on our strategic plan and outline areas of early action as we embark on implementation. Our staff member who was going to present unexpectedly needed to be out today, so we look forward to returning to you with that item at our next board meeting. But today you will hear an in-depth presentation related to one of the most significant priorities in our strategic plan, which is taking on the administrative burdens in our application and member enrollment processes that can make getting into coverage more frustrating and difficult than it needs to be. Extensive research shows that administrative burdens, or what we sometimes call sludge, often prevent the very people who most need the benefits of public programs from getting the services for which they're eligible. And we know our own application process has many of these points of friction. We worked last year with Manat Health Strategies to take a fresh, independent look at where the Health Connector itself is inadvertently imposing administrative burdens on people trying to enroll, the first state-based marketplace to take on a self-assessment or audit of this kind. Having digested its findings, we are now starting to take on the first round of changes we can make relatively quickly to make the process easier for residents trying to get into coverage. At the same time, we're scoping the longer-term plans for making the more fundamental and heavier lift changes to the process. This process will take a number of years to complete, as many of the most impactful changes will take careful systems changes with vendors and thoughtful coordination with MassHealth, with whom we share an eligibility and enrollment system. It's personally important to me that we don't shy away from acknowledging that there are aspects of the way our application and programs work that can and should work in a more streamlined, modern, and less time-consuming way for the public, and committing to do everything in our power to make sure we're delivering an easy-to-use, equitable on-ramp to coverage, more comparable to what the rest of us who get our coverage through our jobs might expect. I know you'll find the presentation by Signe and Sage, both first-time presenters to the board today, engaging. We look forward to your questions and counsel, and will of course keep you updated regularly on our progress. So to come back full circle, over the last 18 years, Massachusetts and the Health Connector have made great strides in providing access to affordable and meaningful health coverage, but we still have more work to do, and we're more committed than ever to tackling the challenges ahead. As always, thank you for your support and your guidance as we continue to move forward.
Sorry, I need to unmute myself. Thank you, Audrey. And I wanted to take a minute to thank the Connector and Connector, Audrey, and the leadership team, everyone who worked so hard to maintain coverage. You know, keeping people on coverage is one thing, but connecting them to a private insurance marketplace that's very complicated, you know, when they lose first dollar coverage, and keeping people enrolled and helping them understand, you know, their opportunities and obligations under a very complex system is the work of the Connector, literally and figuratively. And I think that team's done that very well. I had the opportunity to join the Connector leadership. Feline was there, a lot of people around who care about coverage in Massachusetts at the Healthcare for All event the other night. And the well of feeling and support that I think the Connector received was really just great to hear. And so really my thanks. My first year would have been a lot more challenging, although I can't imagine how. But if this part of it hadn't gone as well as it did, so I really want to thank the Connector and also my fellow board members. I think we provided Audrey and the team with a lot of good guidance along the way, and their willingness to say this is working, this isn't, has been, I think, really helpful to all of us. So lots more to come. You know, Mike Levine always gets anxious when I take a victory lap because, you know, in a process as complicated as this, when 4 million people are redetermined, something's going to go wrong and people are going to lose coverage who shouldn't. So we have work to do going forward, which leads us into the next item, which is going to be the presentation on the redeterminations program and some and the enrollment transition update that will be presented by Marissa, supported by Patricia, Jason, and Elizabeth Lamontagne from the MassHealth team. So I'll turn it over to Marissa with our, I think, the entire board's thanks to Audrey and the team for a job really well done.
Great. Thank you so much, Secretary. Good morning, everyone.
Good morning.
Morning.
So we're now approaching the end of the more than year-long period in which MassHealth selected its entire membership for redetermination. Although that activity is winding down, we expect to continue seeing enrollment activity throughout the course of 2024, building on our new record high non-group health enrollment as individuals redetermined more recently close out their renewal windows and other individuals continue to manage their coverage transitions. We'll provide updates today on Health Connector outreach, call center, and enrollment trends right after we hear from our colleague Elizabeth from MassHealth.
Thank you so much, Marissa. So as Audrey mentioned, we are approaching the end of the redeterminations process. Renewals that all had to be initiated by the end of March, and we'll see those last couple renewals really have their results come through, those renewals be completed by members through the end of May. Since April 1st, our caseload has decreased by about 350,000 members, from around 2.4 million to about 2.05 million. In January, we saw about 21,000 new members join MassHealth and 23,000 rejoin coverage, with 57,000 members departing coverage. In February, we saw about 17,000 new members join MassHealth and 17,000 rejoin coverage, with 122,000 members departing coverage in February. Importantly, as of the end of February, our caseload is around that 2.05 million mark, which is still almost 300,000 above the pre-COVID caseload level. Our goals throughout this process have remained the same, preventing administrative loss of coverage, especially for those most vulnerable, making sure members know what actions they need to take to receive the appropriate health benefit, and maintaining compliance with federal and state regulations. If you flip to the next slide, I can share a little bit about the work that we've been doing to outreach members. Great. Can folks still hear me? I think my video is freezing, but I am dialed in on phone.
Yes, we can hear you.
Yes, we can hear you.
Great. Apologies, folks. So our customer service has managed the increased volume throughout the redeterminations process. Since April, our average speed to answer has been around 2 minutes, and our MassHealth enrollment centers across the state have supported over 7,800 appointments or walk-ins from members, making sure that whether it's an in-person appointment, a telephonic, or a virtual appointment, members have the support they need. We've also continued our outreach to members at a rapid pace. We've partnered with health plans in making over 1.6 million outreach attempts. We also executed over 2 million in grants to expand the community assister capacity, providing additional resources for members to get support in the community. Through these grants, there's over 100 new assisters supporting members every day. And in February alone, these new assisters served over 1,100 households through over 730 hours of member support in 45 population-specific events. We've appreciated the partnership from the Connector, from the organizations across the state, and from the many stakeholders we serve to really make this process as easy as possible for members and making sure they maintain the best benefit that they're eligible for.
Hi, everyone. Good morning. On public and direct communications, we do continue our direct communications effort to newly eligible residents. That's going at the same pace we have before, with the same schedule as we've used throughout the redetermination process. Using that schedule through March, which is a full year of redetermination communications to newly eligible people, we've sent more than 4 million messages. Throughout the year, we have adjusted messaging to try to maximize impact while delivering the information important to people, notably on the next steps members need to take to enroll in coverage, and how to access in-person help through the Navigator program, and also how to shop and compare plans. For example, last summer, fairly early in the process, we added countdown emails reminding people their MassHealth coverage was ending in 10 days or a week, for example, with details on how to enroll or find assistance. Because of the sheer volume of the messages and having people come in, at all different parts of the month, it's difficult to identify a specific message or platform that was sort of like a magic bullet here. However, in our recent survey of people eligible but unenrolled, 84% of people coming from MassHealth remember receiving communications from the health sector in the last 6 months. Those most remembered were mailed notices and email. People coming from MassHealth were more likely to remember text and phone calls versus non-MassHealth members, which makes sense as we try to deliver messaging to devices that are always within arm's reach. We also heard in the survey that reminders to shop or compare and next steps to enroll in coverage and how to access in-person help were most remembered. We've also seen that people continue to enter coverage after experiencing a gap from their MassHealth coverage. We take that as an indicator that we shouldn't give up outreach immediately after termination. People delay for all sorts of reasons, a lot of them financial. But by continuing to reach out, we're reminding them that the door is open for them to get into coverage when they're ready. And this kind of thinking led us last month, for example, to send a reminder to those who appear to have a coverage gap, letting them know that the individual mandate tax penalty grace period of 90 days would leave them exposed to a penalty if they didn't have coverage for April 1st. Through March, our volume of newly eligible people has stayed steady. Every week we send an email. We see who's new and we send them an email to sort of kick off the communications process. That number has stayed pretty consistent through March. As the final COVID protected populations go through their redetermination process, final groups in January are just getting to the point where there are 45 days to respond to end and they're getting a new redetermination. We do expect to see the number of people who are newly losing MassHealth eligibility and become eligible for health connector coverage to start to drop off. But we will continue our full multifaceted direct outreach to those people through mail, email, robos, texts at the same frequency as throughout the entire redeterminations process. And we anticipate keeping this schedule in place at least through June. And then going forward, sort of during regular Medicaid redetermination process, we will have scheduled outreach to people who are losing MassHealth and are newly eligible for connector coverage. We did not have significant outreach in this area before COVID. So this will include sort of an immediate informational message when they're notified of becoming connector eligible, an update early in the next month, and then a final deadline related message before the 23rd of the month. Outside of the direct messaging, in paid media, our specific PHE related stuff has wound down as we have planned. The paid media campaign lasted throughout the year. We generated tens of millions of impressions on those very broad platforms where we invested newly or more than typical, like streaming TV, local network stations, partnerships like our Celtics in-game activities, and then also, kind of our more traditional, more focused platforms like ethnic media across TV, radio, digital, and print. Paid media and in-community activities really help drive visibility and awareness of the health connector and the availability of affordable coverage options. And the year-long coverage ensured that the messaging was registering when someone became newly eligible and needed to take action. If someone saw something in June, it might not register if they were being redetermined in December, for example. So we want to make sure we caught people throughout the process. General messaging is ongoing in a number of areas, including our return to double diabetes on all Red Sox games, That messaging and all messaging generally encourages enrollment, but also specifically calls out those losing MassHealth as sort of a reminder to those people that we are available. Our outreach and communications activities have all been part of the larger Act Now Stay Covered campaign in partnership with MassHealth and Healthcare for All. We are planning an event with MassHealth and HCFA for next month with the community-based organizations and outreach workers that made this unique and effective campaign such a success. The Act Now State Cover teams knocked on 428,000 doors, reaching priority communities to offer redetermination and enrollment support. Additionally, 42 community organizations served as point of contact in their neighborhoods, providing assistance to their clients throughout the year and distributing materials at night. So that is sort of the update on outreach and communications at this
Good morning, everyone. Just a quick update on the contact center. So as we get to the end of the unwind, we continue to be pleased with our overall contact center metrics. March call volume did increase slightly over February and did come in a little bit above forecast. However, we continue to answer calls in under 30 seconds on average and finished the month with a service level just under 90%. We've now shifted our focus to looking at call drivers or reasons why members are calling us. Outside of general application questions and plan shopping, our highest call drivers are enrollment questions and questions related to billing and payments. We'll work with our contact center vendor to start to drill down on specifics as to why customers are calling with questions in those areas, so we can then turn around and work with our enrollment and billing vendor to see how we can make improvements to the system to reduce those call types. Our goal is to reduce the highest call drivers and overall call volume to the contact center. And by working on drilling down to these specific call reasons and making corresponding systems adjustments, hopefully we'll be able to provide a better level of customer service to our members. If anyone has questions, happy to take those. Otherwise, I can turn it back over to Marissa.
Great, thank you, Trish. So over 91,000 of our current enrollees have come to us after losing MassHealth in the last year, reflecting about 24% of those currently eligible. We're also starting to see the effects of what's called program churn, where people are moving back and forth between different programs. We have another 19,000 individuals who were with us at some point in the last year, but are not enrolled right now. Some of them have returned to MassHealth, some are not eligible at all, and some of them may have been terminated for non-payment or voluntarily canceled their plans. Generally, enrollment distribution among those who lost MassHealth is similar to enrollees who did not come from Medicaid, with the exception of our APTC only and unsubsidized populations, which you can see in the two far right bars here, where we have very few individuals enrolled there who lost MassHealth, the green sections of the bars. While we're still seeing active member movement, overall, we expect to end up close to the 135,000 member net growth that we predicted, though we expect it may come past June. We continue to support these individuals, as Jason noted, with a variety of communications related to coverage transitions, and expect enrollment outreach to continue throughout the year alongside the extended special enrollment period for those losing MassHealth. We know you share our keen interest in understanding what's going on with the population of people who are eligible for a Health Connector plan but haven't enrolled. To learn more about what's behind their decision-making, we recently conducted a survey of eligible but not enrolled individuals, in which about 75% of respondents indicated that they had other coverage. And this was consistent among individuals who had lost MassHealth and those who didn't. About half of these respondents indicated having employer-sponsored coverage. Others noted sources like COBRA and Medicare, and others still said they had MassHealth or Health Connector coverage. Some of that was likely due to timing. We know some people had coverage changes after the survey was sent out, but we're thinking through whether some of those individuals could be confused. Do they think they actually completed the process but didn't, and they need some extra support to understand that. We also heard from people who said their other coverage was Health Safety Net, which is not comprehensive coverage. We're going to amend some of our communications and work with assisters to address these topics directly. Nancy, I see your hand.
Okay.
Yeah, Marissa, could you just clarify who exactly is this population of eligible but not unenrolled? Are those the people who were, I'm trying to follow the numbers. I know we heard about 353,000 people were disenrolled from MassHealth. Then we heard 91,000 of those joined the connector, which I think gives us the 25% of eligible. Are the people you're surveying here the other 262,000 people? Like, who did we survey exactly?
Yes. So we surveyed everyone who is eligible for a Health Connector plan but has not enrolled. And that includes people who are eligible because they lost MassHealth, and it also includes other people who may have applied during open enrollment and not signed up. And what we did on the back end was have an indicator so that we could sort out the survey responses to see, are there differences in the population who's eligible having lost MassHealth versus other applicants, and do we need to tailor our messaging in any specific ways when we're speaking to that population? So it was broader, and it did include anyone who could enroll in a Health Connector plan, including those who had lost MassHealth.
And but was it still of some subset of that 353,000? I mean, there are presumably lots of people out in the world and have always been in the world. I mean, we know this, who probably were eligible, but we don't know who they are. So are these just the people known to us?
Yes, these are people who put in an application through our HIC system, and they have an eligibility determination for a Health Connector plan, but they weren't enrolled with us when we selected the survey sample.
Okay, great. Thanks.
Bella.
I was just wondering what the survey sample size was. How many people actually responded?
Yes, great question. So we had a population, we sent invitations to about 216,000 individuals, and we received about 3,800 responses. Eric.
Do we have any sense as to how these numbers compare to other states?
I don't know that I've seen much coming out of other states and work among their eligible but not enrolled populations. I believe we did hear anecdotally from California a few months ago that they were seeing relatively high reports among individuals of having transitioned to employer-sponsored coverage. But I would need to do a little bit more digging on that front to see if any states have engaged in this kind of survey work.
How about further up, going back to the 25-75 split? Is that pretty typical across the other states where only 25% moved over?
It does vary considerably by state, particularly across states where they may have an integrated eligibility system like ours. Other states are what are called account transfer states, where their applications are separate and they're sending files back and forth with Medicaid agencies. Those tend to be a little bit kind of different structure. When we look at our peer states that look a lot like us, I think we're right on track with Washington in the latest data that's been published, and we've been pretty neck and neck with them for quite a while. We also tend to look at Maryland. They're a little bit higher. And so still continuing to see that evolve, lots of different dynamics going on with, the way that they've selected Medicaid populations, and then pauses that some states have done on their Medicaid side for terminations for various reasons with CMS. So it's still a little bit fuzzy, but I would say we compare pretty favorably to many other states, including our peer states that we are most comparable to.
That's great. I just asked because we're not the only ones doing this. If there's anything we can learn from any superstars out there, we're not afraid to steal
Exactly.
Ideas wherever we can.
Yes, no, we do ask when we see those great results and say, well, what's your secret sauce?
And I'll just speak from the broker perspective that you did a great job in the communications. Most of the brokers understood what was happening. They understood the ability to get on employer plans, and they were able to educate their employers. So thank you for all the education you guys have done.
Excellent. That's great to hear.
I will add that I was not in the meeting, so this is hearsay and maybe not admissible. The governor met with the CMS administrator, Chiquita Buchler, and she described the Massachusetts performance and redetermination and, and connecting people through the connector as exemplary. So I'm also getting a notice that my internet connection is unstable. So Elaine, if for some reason I'm supposed to be doing something, maybe you could jump in if I can't. But sorry, thanks.
Of course.
I had one more question on this.
Go ahead.
I was wondering if we can extrapolate from this data and figure out where we are with our 97% insurance rates. Is that coming?
Yeah,
It is coming, yes.
Okay, thanks.
So I'm happy to jump to that. So we've received some new data since we last spoke with you about broader market trends. It's a little bit early to say whether the 97% it has changed or not. We have data, that statewide enrollment data through late 2023 that CHIA recently published. That shows a 0.4% decline in insurance coverage relative to March 2023, just before the redeterminations process kicked off. That's about 25,000 people out of 6.5 million, which is consistent with what DOI is seeing in their data as well. But what I would say is this is still really interim data, and the data into 2024 is not available. And we would expect to see an increase in coverage transitions once that January data in particular becomes available. Anecdotally, we know that we had a very strong open enrollment period. We also know that many employers start their plan years in January. And so we would expect to see that some people who maybe needed to wait to get on their employer's plan would have that effective in January. So this will continue to evolve as that new data becomes available. And so I think we'll continue to work with CHIA and with DOI, monitoring any changes that we can as close to real time as possible. And then we'll have additional metrics kind of nationally to provide that comparison when census data becomes available later in the fall.
The only thing I would add related to data and trends is I think MassHealth, and Elizabeth, correct me if I'm saying this incorrectly, but we're also going to try to take a look at a deeper dive by coverage by community, like, communities of color. We had 25 top communities where most of the MassHealth people live. Is there anything to be learned there by race, ethnicity, residents, anything we can see if there's some inequities or some things we missed despite our best efforts, so that we can maybe pinpoint some areas where we may have been less effective than we hoped. And that will obviously spill over to the connector as well.
Absolutely.
Marissa, can I ask a question?
Of course.
So these data are like 6 months old compared to the MassHealth data we just heard. Is that right? Because I'm still trying to get my head around, if we lost 350,000 MassHealth and we picked up 91,000. Like, I guess the reason that the public coverage only declined by 47 is we're looking at vastly different time periods.
I would suspect that that's the case. Yes, this data is as of September 2023, and it just became available last month to take a look at on that broader scale.
So this actually predates much of what's been going on over the last 6 months. So with all due respect, and I'm sure it's the best data we have, it really doesn't give us much insight into where we're ultimately going to end up, which we hope will be at least where we were when it all started, and optimistically maybe a little bit better, but we actually don't know yet.
That's right. This is the best data available, but it's not great data.
Yeah. Okay.
But can we surmise so far that we're not going from 97 to 87? We're not going from 97 to 91 even. It's while we want everybody to have coverage throughout the state, we can at least say that there wasn't a precipitous decline from the data that we're seeing so far. Is that fair to say?
That is fair to say, and we'll continue to assess kind of what that data starts to look like as we round the corner into 2024. And as soon as we have some insights there that we're able to share, we'll certainly bring that back. We know this is top of mind for everyone, that coverage rate. And so we're eagerly anticipating that picture coming into stronger focus.
Thank you. Great
Yeah.
job.
I mean, the critical missing piece of data is what went on in the private market. Because I think the data show on balance, there's been, as we expected, a large decline in MassHealth, which has not been offset by a decline on the Health Connector. So the hope and expectation is the private coverage will have gone up a lot. But I think what I'm hearing is we don't know yet.
That's right. That's right. We're hopeful that our eligible but unenrolled survey does indicate that strong movement into the private market, but we'll wait for that hard data to become available to say for sure.
Well, and also, I mean, in the best of worlds, we've never had this amount of outreach and enrollment and activity. And we knew before all of this started that we had large numbers of people who were uninsured who actually were eligible for something, but for whatever reason they hadn't enrolled. So the hope is maybe we're going to end up in a better place than when we started.
Yes. Yes. No other questions on this? Although the redeterminations window is winding down, we know that a lot of people still need coverage. We're eager to increase that 97%. We'll continue to support people with outreach, with navigators, with our call center. And we know that annual redeterminations are a standard part of MassHealth's processes. This wasn't a one-time event. They'll continue once this particular cycle ends. And so we're considering what aspects of our approach we want to continue, ways that we can make our work enrolling eligible individuals more efficient and more effective. And we intend to keep a focus on these coverage transitions, both to our own coverage and in the broader market, so that we can minimize friction as members switch programs. So we will be sure to report back findings as they develop in these spaces. And thank you for your guidance as we've embarked on this very busy year.
Great. Thank you, Marissa and team. Any questions? This is great. I think we just need to, I think what you're hearing is a hunger from all of us, like, okay, what does this really mean? Who did it really affect? How do we make sure we're doing as well as we think we are? And so I know MassHealth is committed to that. I know the Connector team is, and we'll, as we get more information and benchmark data, as I think as we've been, the questions we've been asking. So let's see if we can continue to populate these board meetings with just a set of facts so that we have a common understanding going forward, and also where we've missed people, because we have inevitably, in 2.4 million people, we miss somebody. Somebody's standing in line right as we speak at a pharmacy worried about coverage, and we need to do what we can. Of course, that could be for a whole host of reasons, change healthcare and lots of other things, but we need to do our part. So unless there's any questions, I think I'm going to move us on to the next item on the agenda, which is the Administrative Burdens Assessment and Action Plan, which is quite alliterative. But I also think that Signe and Sage will be presenting on SLUDGE, which is equally alliterative. So welcome to your first Connector Board presentation, and very interested in hearing about the work you have to talk to us about. Am I frozen? Oh, brother.
No, we can hear you, frozen.
Oh, okay, good. Okay. Hi, Eric. Sorry. I feel like, okay.
Hold on, I had to unmute myself.
Okay.
Thank you. Welcome. So I'm Signe Peterson-Flieger. I'm the Director of Policy here at the Health Connector, and I'm joined by my colleague, Sage Shaw, the Manager of Member Enrollment and Retention. And today we're going to share the project findings and next steps from the Administrative Burdens Assessment that the Health Connector recently engaged in. So specifically, we're going to provide an overview of what administrative burdens are and why we are focusing on them, share some of the project findings that came out of this effort, and highlight some of the steps that we have taken that are currently in progress, and also other considerations for future actions. So what are administrative burdens? These are the procedural obstacles that can make it difficult for and sometimes entirely prevent people from accessing the programs and services that they're eligible for. Internally, we sometimes refer to this as sludge or a sludge audit, since these are the types of barriers that nobody wants to move through. Administrative burdens can include the learning costs, the time it takes for a person to figure out what the program is and whether they might be eligible, the compliance costs, including identifying and gathering required documentation, and the psychological costs, the stress and anxiety associated with the entire process of applying and enrolling. Together, these costs can make it hard to complete the process of applying and enrolling in a variety of health and social programs. And even when people do make it across the finish line, they can experience significant delays. All of these costs together impose a time tax, meaning they can take a significant amount of time to complete, which is time taken away from other essential tasks of living. We know that these administrative burdens also tend to impact our most vulnerable populations, including individuals and families from communities of color, immigrant or non-English speaking populations, LGBTQ plus individuals, and individuals with disabilities. So to try to reduce these administrative burdens among applicants and our members, over the course of 2023, the Health Connector engaged MassHealth Strategies in an assessment of how these administrative burdens play out throughout our application and enrollment experience. As noted, this effort aligns with the Health Connector's strategic plan goal to improve and modernize the applicant and enrollee experience, as well as our broader health equity goals to reduce the number of people without health insurance, promote retention among current enrollees, and improve the member experience overall. So to assess the scope of administrative burdens faced by applicants and members, Manat reviewed a variety of Health Connector data. They observed residents navigating the website and the application. Specifically, they conducted 15 one-on-one usability testing sessions that lasted about 60 to 90 minutes. They interviewed stakeholders, talked to staff and enrollment assisters. They reached out and discussed other approaches used by some state-based marketplaces, and reviewed the regulatory and at the state and federal level authorities that guide our work. And then they proposed recommendations and priorities for implementation. So what did we find? Broadly speaking, there were several aspects of the application process that caused confusion. Many people take multiple sessions to complete the application. This also means they have to go and find required documents or seek assistance to complete that process. Certain parts of the application were more confusing than others, and we'll discuss these in a minute, including action steps we're taking that are in progress, as well as ones we're considering for future efforts. While there were several recommendations proposed, very few of them are plug and play fixes. And so what this means is we're taking these project findings back, as well as the proposed solutions, to the relevant teams at the Health Connector to do a bit of a deeper dive to understand the challenges identified and explore the proposed strategies so we can assess the best strategy forward within the context of the regulatory, technological, and organizational constraints of our work. So at this time, I'm going to turn it over to my colleague, Sage Shah, who will discuss the details of the project findings and action steps.
Since 2014, individuals apply for coverage through one front door. So one shared eligibility application that we refer to as the HICS system. And they receive an eligibility determination from MassHealth and the Health Connector at the same time. While the administrative burdens assessment touched on all aspects of the eligibility and enrollment process, the HICS application featured prominently in its findings, given that it's the primary way many people interact with us. As people navigate through the application, they're able to select whether they want to apply for subsidized or unsubsidized coverage. At the end of the application process, the system determines a person's eligibility, and the necessary notices and communications from each agency start to come into play. Then for people who are eligible for a Health Connector plan, they move to our payment portal system that allows them to pay for their coverage online and view their Health Connector notices online. And you'll see as we move through the rest of the presentation that each of the areas in our project findings correspond to a specific spot in the eligibility and enrollment process. Manat bucketed their recommendations into 6 main areas throughout the member journey. Some items are specific only to the Health Connector, while others require significant coordinations with our colleagues at MassHealth or further coordination with the HICS project or a potential procurement. We're grateful to MassHealth for their collaboration in responding to these findings. Identity proofing is typically the first place people interact with our HICS system and the application for coverage. For confidentiality reasons, before being allowed to create an account, people are presented with a series of multiple choice questions that are composed from various data sources. For those with a limited credit history, those who may not understand the questions, or people who are applying for other people in their family, moving through the identity proofing process can be frustrating. If people fail identity proofing online, either by answering the questions incorrectly or the system not being able to generate enough questions, they need to submit documents that show that they are who they say they are. This delays the start of their application because they need to factor in time to submit documents and wait for approval. People who fail the online identity proofing may think they aren't eligible or may think they need to submit a paper application if they can't move forward online. And just for context, we receive about 1,200 calls at our call center per month related to identity proofing. We currently have a team put together with our MassHealth counterparts to address a few items related to identity proofing, expanding our current list of acceptable documents, updating our identity proofing notice template to account for those additional documents, and updating our website at mahealthconnector.org. This requires coordination with the HICS security team, our respective legal teams, so that all acceptable document types are represented accordingly to CMS. Some of the items you see under consideration need additional research in order to determine the levels of complexity. Things like system impact, current contracts, cost, operational impact, and/or training. If someone provides information in the application that requires additional proof, they will receive a letter called a request for information. And that tells them what they need to provide and the due date for when that document needs to be submitted. People who may have to send in multiple types of verifications, or people who may have recently moved to Massachusetts and don't have a lot of documents, often face significant challenges for enrolling in and maintaining coverage. Currently, applicants can provide those documents a few different ways. They can upload documents to their online account in the HICS system. They can send a fax, they can mail their documents, or they can drop it off in person. When people submit their documents, they also don't know whether those documents were received until the documents have been processed and approved or denied. In some cases, not providing verification documents by their due date would put the person at risk of losing coverage. In other cases, people could lose their subsidies. Similarly to our work on identity proofing, we have the same MassHealth Health Connector team working to expand our list of acceptable documents for other eligibility criteria. We also have an internal team reviewing data related to verifications for residency, for example, to see if there are ways to streamline the process. While many of our navigators already outreach their own clients who have outstanding requests for information, we are evaluating current additional outreach approaches to this population. The areas under consideration require changes to the HICS system functionality that would need to be approved and slotted into a future system release, typically scheduled twice a year, or would be a significant lift by our operations and communications teams to update or create user-facing materials. Also keep in mind that we need to have the expanded document list approved before we can start further construction on some of those user-facing materials.
And Sage, we have to have it approved by the feds, or who has to approve it?
So they'll go through the legal teams for both agencies, MassHealth and the Health Connector. We have to present the approved documents to the HICS security team so that they can be filed accordingly with CMS.
And I assume one of the reasons that we hired Manat to do this is that they have given us in all of these areas suggestions of states that maybe have best practices we might want to look at. Is that the case?
Yes, and we are currently looking at the suggestions that Manat provided to see what other states are accepting as their approved list of documents.
Great.
And more broadly, Nancy, I would just say that was part of the project scope, was that they looked at, are other marketplaces doing this better? Are we essentially in excess of what's federally required? And there's more artful, simple ways of doing some of these basic program integrity functions. They also looked at what the federal marketplace does. So there was a big kind of a wide swath of places that they were looking. And just as a side note on the CMS side, CMS was really interested in this project and actually asked that we brief CMS leadership on our findings because they found it really interesting for their own federal marketplace. So it was a really fruitful conversation.
Yeah, having gone on the federal marketplace, I suspect there's much they could learn from this.
I think in both directions. There's actually places that they're doing better than us.
Yeah, no, it's true.
So, but I think the fresh eyes on this is important because a lot of states and the federal marketplace, these things were built in 2014, and there's a lot of, there's opportunity for fresh thinking about it and not just the inertia of, oh, we made a decision in 2014, it had to be this way, and not taking the opportunity to go back and look with.
Well, and there were a limited number of vendors who helped too, so a lot of the states look very similar, embedding either best practices or not best practices. Exactly. Okay, thank you.
And would this these issues kind of be more acute now that we're managing a larger immigration population? So this is top of mind.
Absolutely, Eric. I think that's a great point. I think both we have a different, differently configured population we're serving in the public generally, but also I think our focus on equity being more acute and thinking about ways we need to design our programs to account for some of the particular barriers we know some populations are going to face. To Sage and Signy's point, we know some people who may have less documentation or maybe new to Massachusetts are going to be more likely to run into these issues, and that calls into question the equitability of these systems and these programs. So it's such an important time to take a look at it.
Well, we know that many of the people who have remained uninsured despite being eligible for things are in disproportionately in some of those populations. So anything we can figure out about making this process easier and more understandable and seamless so we can get more of those people into coverage is really important.
Absolutely. Thank you.
All right. So as
sorry, I was just trying to mute myself, but I have this theory that, that we probably are missing pockets of people in places we don't expect to look. Like we worked, we kind of blanketed 25 communities. I can't remember the number, and maybe there's, maybe there's people, I don't know, make it up, who are MassHealth eligible in Winchester and we didn't find them. And so I feel like there's I think looking, digging in a little bit to, race, ethnicity, location, all of the elements of true equity, I think will help us get a better handle on what else we need to do and how we can, and then what parts of the sludge are most detrimental to their ability to reach.
So as we navigate through the household and income sections of the application, you'll see that those who are self-employed or who have seasonal employment often find it challenging to present their income, especially since we don't account for income timeframes. People are also unsure about who is considered a household member. Even though we provide guidance on who can be included on an application, family composition can be complicated. For example, you can include the people listed on your tax return even if they don't live with you, and you can include people who live with you even if you don't file taxes together. In coordination with the HICS System Project team and with the effort underway that focuses on the modernization of our online application, we are reviewing how income and household information is asked in other states or agencies within the Commonwealth, and are modifying the wording in our online application to more clearly account for the challenges that our users are facing. Along with modifying the wording in the online application, we will need to update reference materials and mahealthconnector.org so that users know how to answer updated questions. For example, there is an optional question that asks about reconciling advanced premium tax credits at tax time, and we've updated the language in the online application to be more clear in our ask. Notices in general are a pain point for our members, especially our mixed household families, which means that some people may be eligible for Health Connector coverage and others are eligible for coverage through MassHealth. After the application is submitted, households typically receive multiple lengthy notices, which creates confusion about where they are getting coverage and what their next steps are. The Health Connector sends notices at the household level, and MassHealth sends them at the individual level. And families who receive notices may be out of order, may be confused about which notice accurately represents the coverage that they are eligible to receive. Notices for the Health Connector and MassHealth are also not kept in the same online portal, which makes logging into other portals and finding notices somewhat challenging. The Health Connector is currently engaged in a full review of all notices to find ways to improve communication. We are looking at edits to wording, language, tone, the length of the notice, the ease of reading, font size, as well as adding very specific actions that the members need to take. We are also exploring the use of QR codes on notices to enable immediate access to the member portal to make payments or view notices online. In addition to a notice review, we are exploring ways that we can expand our access to notices online and ways we can alert members that they have a new online notice. Looking at other states, some have integrated notices with their Medicaid agency and others do not. While we do not have integrated notices, we may be able to work closely with MassHealth to add coordinated content to our separate notices so that members receive more consistent messaging. Now, when people first log into their account, the account dashboard is the first thing that they see. It's got so much information that people don't often know what they need to do next, what action they need to take. While we internally know the differences between a request for information and a notice, our members typically do not. So while those items may be called out differently on the account dashboard, members may not know that they have to go to different places to complete all of the action steps, which can lead people to not completing everything they need to do to enroll or remain enrolled in coverage. As mentioned previously, we're in the process of a major user interface modernization effort for an upcoming HICS system release that goes live later this year. We'll see a revised account dashboard that more clearly calls out action steps for our users. And we will continue to collect member feedback to understand what's working and what's not, so that we can take that into consideration for future improvements to the HICS system. And for our premium payments, the Health Connector currently accepts check, money order, or online payment from a checking or savings account. What this means is that if people do not have a checking or savings account, they cannot pay their premium online. Members have told us through feedback through our sister community and through various surveys that they are interested in more payment options. So when looking at what other states are doing, some of our peers accept any payment type that the insurance company accepts. And we've also seen that credit cards seem to be a very popular form of payment. Just recently, we included a question on our survey of eligible unenrolled individuals about whether the addition of other payment methods would prompt people to enroll in coverage. We also engaged with members through various surveys over the years, as well as heard feedback through customer service that having additional payment methods would be helpful. We know that credit and debit are options, as are e-wallet options or payment at a retail or banking location. And we want to make sure that the pathway that we choose is responsive to member needs. Internally, we are beginning some projects in 2024 and early 2025 that review our current payment methods in more detail, proposing an expansion of payment options that take into account cost and convenience to the customer. In parallel, throughout 2024, we're looking at ways that our current customer service model can better assist people who need that enrollment and payment support with the payment options that we currently have.
Yeah, Sage, I think this is an area that it's great we're looking at. And as the parent of a 25-year-old who has never in her life written a check and doesn't have a checking or a savings account, she would think this is so last century. And I think, particularly we know so many of the people we serve are younger. So I think we really need to get with the way that the current generation pays for things.
Elaine?
Elaine?
That's a ditto to what Nancy.
Elaine.
Hi, can you hear me?
Yes.
Okay, good. I was going to say ditto to what Nancy mentions, parent to a 20-year-old, and yes, everything's last century.
Yeah.
But it also makes me think where I'm instinctually wary about things artificial intelligence. One of the things I've come to understand is there's certain places and spaces where I think it's important for like systems checks and being able to identify issues with different systems where artificial intelligence may be or most likely is important for us to look into, understand, implement. I think the QR code piece that was raised a little earlier is one, and I'm sure there are plenty of others that I can't in my old generation mind understand, but I'm wondering if in the suggestions, recommendations, if they're lifting up like new strategies that are associated with AI.
Yes, that's definitely going to be part of the conversation around the payment methods through 2024 and early 2025.
I had a question. I realize you're trying to get onto the next slide, but before, did you guys consider and reject? There's like all these startups in this space, companies that can connect people or simplify insurance plans. Did you look at any sort of a better way or a different way to do business as it relates kind of to Nancy's point about the people we're trying to reach think about things differently. They often come from different parts of the world where technology systems are more advanced or people just have health insurance. So any thoughts about that?
I can add, I think if we're talking about the whole system in terms of the entire application process and shopping experience, I think we're in a place now, and certainly welcome feedback from the board, where we're so deep into the development and sort of lifespan of the very complex, very costly system that we've built in the Commonwealth between the Health Connector and MassHealth. And I think we've been chiefly focused on what are the improvements we can make in that system since it's been so delicately and arduously built. That being
on a 30-year-old platform. Yeah.
Right.
Yeah, okay. Exactly. I hear you. Okay. So there's no app for that.
Well, no, however, there's other pieces of the way that the public interacts with that system and the process of getting into coverage where there may be opportunities to add on features or modernize kind of the wraparound experience for people, whether that has to do with how they pay, which is outside of the HICS. So we have flexibility and latitude there, from a systems perspective, once we do that careful consideration that Sage was talking about. There's also other tools we can think about in the way of decision support, right? So, and this is separate from what people do in MassHealth, but in a commercial marketplace, people are comparing, in some cases, dozens and dozens of health plans and how do they make the best decisions about which ones have their providers in their network and what their risk tolerances for cost sharing and things like that. So there's an increasingly large suite of tools that are available that it takes careful consideration to think about how they interface with our system and what opportunities might make sense for us. So I definitely want to indicate we're very open to and receptive to that. But there's different kind of tree trunks of the system, some of which are more kind of embedded than others. But definitely trying to think about this whole space with fresh eyes and really trying to put ourselves always in the shoes of members and applicants and the very people we're trying to reach, particularly those people who, have different barriers, whether it's because they're unbanked or whether it's because they don't speak English as a first language or they've never had health insurance before or new to the US. So that's kind of our North Star when we think about building on the current and adding additional features.
Great. Thank you. Thank you, Audrey.
I might just add to that as well, if I could, that I would state that there is a difference between a transactional system and decision support systems. I think that's where you're maybe getting at, Audrey. And we could use one system for transactional work, and maybe we continue with that. But when we talk about decision support, there's a lot of great activity out there using AI, using algorithms to help people make better choices, to do the math for them, that type of thing.
Absolutely.
So I don't think they're mutually exclusive.
Agreed.
Yeah.
Thank you, Eric.
I think to dovetail a little bit on the point made by Eric and many others, I think over the past 8 years or so, we have spent a lot of time looking at the work that we're doing from a system perspective, more or less from the functional aspects. There've been a lot of energy put into getting the function to work correctly. And I think we are at a point now where we need to incorporate all of the things that have been said, but also start to look at our systems from a value perspective in terms of the value chain for the end user. And as we talk about UI and UX design as it relates to our systems, we need to really start thinking about the constituent that we're servicing and what is the value chain from their perspective and what they expect to get from the system, and make sure that we're doing a good job mapping that into this sort of like functional systems that we have built, where we can factor in the decision support tools, the AI aspect, to ensure that we're capturing what our constituent is expecting, be it someone who newly arrived to the US whose English may not be their first language, or someone, as the secretary alluded to, who lives in Winchester, who grew up here all their life, but still having the same difficulty navigating through the application as others who are newly arrived. So looking at it more from a horizontal perspective as opposed to the vertical functional aspects may allow us to produce a much better tool in the long run for our constituent.
Thank you for that, Dimitri, and couldn't agree more. And I think that's why this project was so energizing, I think, for the connector to undertake, because it was really us sort of trying to step back from how close we are to these systems. And to your point, we've been so focused for so long on just the basic functionality of these systems, obviously incredibly important, but I think we're ready to move to a place where we're putting ourselves in the shoes of the end user in all of their incredible diversity. When we think about the 350,000 people we're serving today, the 1.1 million people we've served over the last decade, I will confess, for people who work in programs like this, you can get so close to these systems that you stop seeing them the way regular people would see them and experience them. And part of this project was actually watching people go through the application. And I will tell you, it was not a comfortable experience to watch regular people who'd finished their long day at work, got their kids dinner and into bed, and then sat down to do an hour-long application to get health insurance coverage. And a lot of it does not work in a way that's intuitive and that people in 2024 expect their kind of online e-commerce major life decision-making processes to work. And I think we need to own that and think differently about it. And I think we're fortunately in a place from a stability perspective where we can afford to do that, but it is going to take a shift for us from an organizational perspective to really set that bar higher, to think creatively, to put ourselves in the shoes of the public, not in the shoes of program administrators who are close to it and know all of the background about why it works the way it does and maybe why that's really okay, but really challenge ourselves to do better.
I think we just need to set the bar, or our goal to be that we want to make this as simple as someone going to Amazon and purchasing a trinket on Amazon and getting it delivered to their door. And that's something today that it doesn't matter your background, you can go online and buy something from Amazon and get it delivered. So if we can set that as an objective to simplify the process or simplify the workflow to the point where that can be done while maintaining the integrity that we need to have around what I would call the pain principle, privacy, integrity across the board for everything that we're doing, that would be very helpful and very useful.
Agreed. Yes, simplification is, I think, a governing principle for us in this work. Eric.
Yes, I have a really basic question. I didn't see a lot of detail on language in these slides. Have we solved for that already? So the new resident here who speaks Haitian Creole primarily and not much English, are we already doing a good job with that, or was that looked at and addressed as part of the analysis?
It wasn't an explicit part of this. This was more about the sort of the journey and how the process works. I don't know if Sage or others want to speak to kind of where we are with respect to the system right now on language. That is a key area of focus for us, again, from an equity perspective in terms of enhancements to the application process itself. We do provide, of course, language supports through our contact center and through our navigators. The application itself, though, Sage, I might ask you or others to speak to state of play there in terms of what is and what's coming.
Yes, so English and Spanish and Portuguese was just, I believe it's just recently went into effect, and that's with our notices. It's different for MassHealth. MassHealth offers additional languages in their noticing, but those are our languages right now. And as Audrey had mentioned, during the MassHealth redeterminations period, our contact center did begin offering even more expanded language options for users when they contact customer service with questions about the application.
And Eric, we'd be happy to come back and do a special presentation on all things language, since it's broader than just the system, although there are things slated from the application and online experience perspective. But kind of our language access plan overall is an area we're doing new focus. So we'd be happy to come back and do kind of a fuller, more detailed presentation on everything language, which is huge.
Thank you.
That would actually be good. Elaine.
Yes. No, that would be great. But just to clarify, in the kind of observation of people walking through the application, was there an observation of someone that speaks a different language actually completing the application in a different language?
I don't believe there were non-English speakers in the observed user testing. Signy, I know we chatted about this week, so you could feel free to jump in. I know Manat was looking for a broader array of individuals and languages spoken, but had challenges with recruitment. So I believe they were all English speaking, which is a shortcoming.
Mm-hmm.
Okay, I think if I don't see any other hands, although my internet is like wobbly. But so let's let the team finish up, and then I think we are minutes away from calling for an adjournment. So I'd love to hear. I don't want to cut off the conversation. Any other comments? So I don't know if Sage or Signy are going to take us home.
Yep, that's me. All right. So in summary, the Health Connector recognizes that the administrative burdens assessment plays a critical role in our strategy to improve the applicant and member experience. As we think about reducing racial and ethnic disparities in health insurance coverage rates, we realize that implementing recommendations in this administrative burdens assessment will help alleviate some of the frustrations experienced by people of lower income and communities of color. We will continue to work with our MassHealth counterparts, our vendors, and other stakeholders to help address the barriers to coverage that applicants and members are experiencing. And throughout 2024, we plan to provide the board with updates as well as opportunities for additional input.
Great, thank you. Thank you very much. I really want to commend the group for, it's hard to look at yourself and cringe when you watch your own processes that make things so challenging for people. So I appreciate that you guys are doing it. I think my only, Audrey, unless you correct me, my only official job is to ask for a motion to adjourn and then take a roll call unless there's any other comments.
No, that is it.
Good. Yeah, we're giving you back the gift of time, which is this time of year is very valuable. So Kathy, if you could just if I could get a motion in a second.
So moved.
Adjourn.
So moved.
We can do the roll call and we'll see you next meeting.
Okay, Rebecca?
Thanks, Audrey.
Yes.
Okay, Elaine?
Yes.
Bella?
Yes.
Eric?
Yes.
Martha? It was Martha. Robin?
Yes.
Dimitri?
Yes.
Secretary?
Yes.
Nancy?
Yes.
Matt?
He dropped off, Kathy.
Okay.
Yeah,
all right, thank you.
he was in the chat as having to drop off.
Oh, okay. So that's it. Thank you, everyone.
Well, thank you. Thanks,
you.
everyone. Thanks, Audrey and the team, and we'll see you next meeting, and we'll bring back the strategy update, hopefully at that time. It's great to see everyone, and congratulations on all the good work, and we'll catch up.
Take care.
Thank you. Thank you, Secretary. Thanks,
Thank you.
everyone.